Respiratory. I am a pediatrician and neonatologist working in Dubai in United Arab Emirates. Today we are going to discuss the subject of late preterm in details. Before starting, I would like to tell you that I used both Gomella 2020 and Fetal and Neonatal Secret. Both were my main source in preparing this lecture to be up to date as much as I can. Also, I have two requests, please. First one, please go to video description at the bottom, and you're going to find a PDF file called Late Preterm. Please download it to be able to follow me and to put or to add notes if you would like. Second request, please go to your right upper corner of this video on the YouTube and change the resolution to 4K or at least 1080p to be able to visualize the content in a better way. And now, without further ado, let's start. Before digging deep in the subject of late preterm, I would like just to give you some overview about the subject. There are three pieces of information I would like you to know because they are very important. First, a piece of information that most commonly agreed upon definition of a late preterm infant is an infant born between 34 weeks and 36 plus 6 weeks gestation. Starting from 37, he will be full term. Second piece of information that late preterm birth represent approximately around 74% of all preterm birth. Last piece of information that these infants they've got increased risk for both short and long-term complications. Please keep those informations in your mind because we are going to use them later on. You know, basically, as per guidelines of American College of Obstetrician and Gynecologists, induction or scheduled repeat cesarean deliveries before 39 weeks should be discouraged. However, not all late preterm deliveries are preventable. There are some potential etiologies that we cannot prevent it, and that will take us to the next step, which we need to know what are the indications of deciding to deliver the baby before reaching 39 weeks gestation. First common indication if the mother is suffering from preeclampsia, because the more we are going to keep the baby in the uterus while the mother is suffering from preeclampsia, the more we are expecting more complications for the baby, and that will be discussed in the preeclampsia video. Next indication is spontaneous premature rupture of membrane, because that will create a potential intrauterine source of infection. Multifetal gestation, that's the third indication. Antepartum bleeding, of course, there will be a high risk for affecting the baby. Last indication for preterm delivery is fetal growth restriction. It's very obvious and it's very common that whenever the baby is not growing in the intrauterine life, we need to deliver this baby to avoid some complication that we are going to discuss in the video of fetal growth restriction. And now we need to know what are the complications expected in case of late preterm baby. First and most common complication is hypothermia or temperature instability. You know, they are more likely to suffer from hypothermia due to the following reasons. First one, that late preterm, they've got immature epidermal barrier. You know, thin skin that will lead to more heat loss. Logic. Second cause is a higher surface area to body weight ratio. You know, late preterm, they've got a very large surface area that's exposed to the air, and that again will lead to more heat loss. Third reason, cause, you know, the late preterm, they've got decreased amount of brown adipose tissue, or they call it BAT, which is brown adipose tissue is very important for two things. First, for insulation. Second thing, for generating heat in those babies in case that the temperature decrease below the threshold. Last reason why the baby late preterms are more likely to suffer from hypothermia, that they are more frequent delivery room intervention. When the preterm babies, they've got higher chance to be exposed to more procedures that most of the time will be done in the room air after getting them out of from incubator. So they're going to be exposed more to room air other than the well-controlled atmosphere in the incubator. So those are four causes, explaining why late preterms they're more likely to suffer from hypothermia. Next complication, it's more on the long-term side. Preterm infants are they've got an increased risk for long-term adverse neurodevelopmental and psychosocial outcome. For instance, they are 3 times more likely to develop CP and 1.5 times more likely to develop mental retardation, compared to term infants. They're also more likely to have poor school performance, learning disability, ADHD, which is attention deficit hyperactivity disorder, and also, they're lower likely to complete high school. Next complication is the respiratory morbidity. Preterm babies are more likely to develop some respiratory complications if you compare them to term infants or term neonates. First complication is RDS, respiratory distress syndrome, and this is secondary to immature lung architecture and surfactant deficiency, deprivation of normal hormonal changes occurring at term that promotes the clearance of lung fluid. So those are 3 causes that makes the baby more vulnerable to develop RDS. Also, those babies, they have higher chance to develop pneumonia or chest infections. Also, they're more likely to have apneas that may lead to sudden infant death syndrome. Also, they're more likely to have a respiratory syncytial syndrome. Respiratory syncytial virus infection. And that increased susceptibility is due to incomplete lung development, immature immune system in late preterm, a relative lack of passively acquired maternal antibodies, etc. And there is one very important note here I would like to mention, that late preterm infants do not qualify for palivizumab prophylaxis unless they have additional risk factors such as hemodynamically significant congenital heart disease or any other congenital disease that will qualify them to use palivizumab. That's why precautions such as decrease contact with sick individuals or good hand hygiene by those handling the baby, it's very effective in reducing the infection for those babies. Next complication or difficulty that we are going to suffer with late preterm babies, that is poor feeding. This is due to lack of feeding skills, like poor latching, for instance. They take long time, sometimes 7 days or more, depends on their gestational age, to be able to latch properly. Next reason is sucking and swallowing coordination. We will usually have swallowing coordination abnormality that will lead to delay in milk production of the mother, because the milk production is related to sucking, and that will increase again the risk of lactation failure. Last reason is immature intestinal motility for those late preterm babies. Those 3 reasons will lead to poor feeding. Next complication is the jaundice. Jaundice is very common in preterm, and by the way, that is the most common cause of readmission in case of after discharging the late preterm from SCABU or from NICU. The most common cause of readmission is jaundice, and jaundice is happening secondary to hepatic immaturity. The liver is still immature to get rid of the biliverdin or bilirubin and transform it to biliverdin. As well, you have difficulty in establishing feeding, and difficulty in feeding will lead to more jaundice for many reasons. One of them is dehydration, and again, feeding will help the liver maturity, and if you have a poor feeding will lead to hepatic immaturity again, and hepatic immaturity will lead to jaundice. And it's very important to note here that when you have high bilirubin, you have increased risk for bilirubin-induced neurological dysfunction again. And of course, that's due to immaturity of the blood-brain barrier and decreased bilirubin binding. Again, I would like to remind you that hyperbilirubinemia is the most common reason for hospital readmission for late preterm infants. Next complication is infection morbidity. Late preterms, they have increased risk for infection because of the immature immune system. And from top, if I'm going to start from top, then moving downwards, starting from meningitis. They're very common to have meningitis, sepsis. We mentioned already pneumonia and RSV. And even necrotizing enterocolitis in the GIT as well. Last complication that I want to discuss with you today is hypoglycemia, and this is secondary to delay in the activity of hepatic glucose phosphate, which is needed in the final step of gluconeogenesis. Hypoglycemia in late preterm infant exacerbated by poor feeding. If you don't have a source of glucose, again you will have hypoglycemia, decreased body weight, and low glycogen storage at birth. After we discuss the complications, it's important to know two pieces of information. The first piece of information that late preterm babies, they are more likely to die within the first 28 days of life as compared to term infant. And second piece of information that with the case of preterm, there will be increase in cause of stay, and most common cause of delayed discharge in those babies are first jaundice, second poor feeding. The last point I want to discuss with you today in the subject of late preterm is the discharge criteria. When to be able to discharge the late preterm infant or neonate confidently. First, absence of medical condition requiring further hospitalization, like for instance hyperbilirubinemia that I mentioned as a cause of long stay, and RDS, for example, as well the poor feeding. Stable, next criteria is stable vital signs and cardiopulmonary status for at least 12 hours before we discharge the baby. Third, maintaining thermoregulation, maintaining temperature of 36.5 to 37.4 in the open crib, not in the incubator. Next is the at least 24 hours of successful feeding in the absence of excessive weight loss. Next is a formalized evaluation of breastfeeding. We make sure that the mother is feeding well, it's taught to feed well, and the baby is latching well and sucking well. Next is passage of stool. Make sure that the baby is urinating well and pooping well. Next, successful completion of a car seat safety. You need to keep the baby testing for car seat for 2 hours, 3 hours, depends on the guidelines in your department. Next, screening of hyperbilirubinemia, and make sure that the baby is acceptable level, and make sure that you're going to bring him for follow-up very soon to avoid sudden rise of serum bilirubin. Next, assessment of family and home environment. Make sure that the baby will not be at risk of any way. Last one is follow-up visit. It should be within 24 hours to 24 to 48 hours max after discharge, to be able to detect if any problem going on with this baby. Thank you so much, and that's everything for today.